Hello and welcome to Health Me Please channel. Today, we're going to be discussing about COPD, or Chronic Obstructive Pulmonary Disease. COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms due to abnormalities of the airway and/or alveoli that cause persistent, often progressive, airflow obstruction. Substantial overlap exists between COPD and other disorders that cause airflow limitation, such as emphysema, chronic bronchitis, asthma, bronchiectasis, bronchiolitis. Common presentations of COPD include patients with few complaints, but an extremely sedentary lifestyle. Patients with chronic, daily respiratory symptoms such as dyspnea on exertion and cough, and patients with recurrent acute exacerbations such as wheezing, cough, dyspnea, fatigue. Patients should be asked about current smoking and the number of pack years smoked, packs of cigarettes per day multiplied by the number of years. The physical examination of the chest varies with the severity of the COPD, but is often normal in mild disease. The diagnosis of COPD should be considered and spirometry performed pre- and post-bronchodilator administration in all patients who report any combination of dyspnea, chronic cough, or chronic sputum production, especially if there is a history of exposure to triggers of COPD such as tobacco smoke, occupational dust, indoor biomass smoke, a family history of chronic lung disease, or presence of associated comorbidities. COPD is confirmed when a patient with compatible symptoms is found to have irreversible airflow limitation, i.e., a post-bronchodilator forced expiratory volume in 1 second, FEV1, forced vital capacity, FVC, ratio less than 0.7, or less than the lower limit of normal, and no alternative explanation for the symptoms and airflow obstruction. In general, all symptomatic adults with fixed airflow obstruction on spirometry should be tested for AAT deficiency, preferably with an AAT serum level and genotype, with the possible exception of patients from geographic areas with a low disease prevalence. In the evaluation of patients with COPD, chest radiography is typically performed to exclude alternative diagnoses, evaluate for comorbidities, or assess a change in symptoms that suggests a complication of COPD. Chest computed tomography is performed to evaluate abnormalities seen on the conventional chest radiograph, to exclude certain complications of COPD, or when a patient is being considered for lung volume reduction surgery, endobronchial valves, or lung transplantation. Among patients who present in mid or later life with dyspnea, cough, and sputum production, the differential diagnosis is broad and includes heart failure, COPD, interstitial lung disease, thromboembolic disease. The original gold staging system was based solely on post-bronchodilator FEV1. Although well recognized and commonly used, it has been criticized for underestimating the importance of the severity of symptoms, risk of exacerbations, and presence of comorbidities in predicting outcome. The revised GOLD ABE strategy uses a combination of an individual's symptoms and history of exacerbations and hospitalizations due to exacerbations to stratify symptoms and exacerbation risk and guide therapy. In terms of pharmacologic management, patients with stable COPD can be categorized according to the severity of symptoms and the risk of future exacerbations. Symptoms should be assessed using a validated instrument such as the Modified Medical Research Council (MMRC), dyspnea scale, or the COPD assessment test (CAT) are preferred.